Now we are live in YouTube also.
Okay.
Sir, shall we start, sir?
Yeah. No problem.
Okay.
At this outset, I welcome you for this third edition of the e-Gurukulam. It's a presidential action plan organized by our President, Dr. Somasundaram, sir. I welcome Dr. Somasundaram, sir. I also welcome our esteemed teacher, Dr. Balasubramaniam, sir, who is the convener for this action plan, who is the convener for this program, e-Gurukulam program. Welcome you, sir. I also welcome Dr. Manikumar. Dr. Manikumar is a neonatologist from Chengalpet Medical College. He did his undergraduate from Stanley, and he did his post-graduation from ICH and DNB from Childless Hospital. After that, he completed his DM from ICH and is currently working as an assistant professor. A good friend of mine, my batchmate, a highly intelligent person who bisects everything, who always reads protocols and who always reads guidelines, consensus statements, and protocols. So I welcome you, Manikumar. It's an honor for us to have you in this program. And I also welcome Dr. Somashekar, sir. I think
Dr. Prasanna, ask her to put off the slide before. Just stop the slideshow before.
Priya, can you please stop sharing the slideshow?
Wait for a few minutes. Yeah.
So I also welcome Dr. Somashekar, sir. He will join us with us in a few minutes. He's another mentor. Dr. Somashekar, sir, needs no introduction. He's a former vice president of IAP, National IAP. Sir is currently working as professor in Mada Medical College, active participant in all the programs, especially he's well-versed in nutrition. He's a IOCF state person. I also welcome Dr. Priya. Dr. Priya is a third year postgraduate from Savita Medical College. I thank HOD and faculty of the Savita Medical College for giving her this opportunity. So without wasting much time, we'll start the session. Can we start, sir? Yeah.
Please go ahead.
Yes, sir. So we are also live on YouTube. So I've started YouTube live streaming. So we'll also be live on YouTube. Manikumar, you can start. You can take your time. You can discuss for at least 1.5 hours. So you can take your time. I think you would have planned your session. Thank you.
Okay. Yeah, thank you. I think we are good to go, Dr. Priya. I think we can start the presentation without wasting much time. Yes. Yeah, please share your screen. Yeah.
Good evening, one and all present here. I'm Dr. Priyadashni. I'm here to present a newborn case. A baby of Navina, 11 days old male baby, born on 14/3/24, 1 p.m. at 32 weeks of gestation by emergency LSCS at Savita Medical College and Hospital with a birth weight of 1950 grams, was admitted in NICU for respiratory distress and was on respiratory support for 9 days. Currently, the baby is in room here. It was on IV antibiotics for 5 days and phototherapy was given for 2 days. Informant is mother and her reliability is good. Present in illness. Presently, the child is for monitoring weight gain and ROP. She is currently taking adequate 2-hourly feeds via Paladai. Baby is on KMC for about 10 to 12 hours per day. Baby is currently receiving multivitamins, passes urine and stools adequately, and no specific complaints by the mother. Antenatal history. Mother's age is 30 years. Her height is 156 centimeter, weight is 58 kgs, and BMI is 24.1. She's married since 11 years. Obstetric code is she's a multi G5 P.
Manikumarji, can we intervene at this juncture?
Yes, sir. Yes, sir. Yeah.
Yes,
When the
sir.
presenter was saying
Welcome,
about welcome, thank you very much
Welcome, sir.
for the opportunity. I'm sorry, feeling sorry for the late joining, and I was traveling just now. I came, and the presenter is saying that the child is receiving multivitamins, and anything else apart from multivitamins is the baby is being given.
Currently, the child is on multivitamins.
What is your understanding about definition of exclusive breastfeeding?
Only breastfeeding she is getting, sir.
No, what do you understand by the terminology definition of exclusive breastfeeding?
Only breast milk. Other than that, medications we can give. No water or anything like that. Unless breastfeed, we don't feed
No,
any.
the question precisely is that whether it is only direct feeding or express feeding is also allowed.
Now the child is getting express breastfeed from Pala Day, sir.
No, can you still call it as exclusive breastfeeding? Okay, that is one thing. And baby is also receiving multivitamins in addition to breastfeeds.
Yes.
Can you still call it as exclusive breastfeeding?
Medication.
That is a precise question.
Unless prescribed by treating physician. This is what the definition fulfills.
Exactly.
And to continue until 2 years and beyond, ad libitum. That's what is the definition. But here you mentioned about multivitamins.
Yes, sir.
But what exactly you want to convey to the people who are listening?
Which multivitamin should I specify, sir? Vitamin D.
No,
Okay.
no, you are right. See, the baby is receiving multivitamin. That's good. But
Okay.
apart from that, anything else, any other supplements? I'm just asking you.
Caffeine is also the baby's receiving.
Is the baby, as per the IAP recommendation, is the baby getting, suppose, for example, vitamin D? When will you start giving vitamin D3?
2 weeks of.
And if it is iron?
Iron will start at 4 weeks of postnatal life, and multivitamins.
It is the same for term and preterm, Manikumar sir?
No, actually, for these preterm babies, we will usually start at somewhere around 2 weeks itself. We can start this being a 32 weeks, and once the baby has started to gain weight, we can easily start. This is the same as in case for severe malnutrition, right? Severe acute malnutrition, even though you know that the baby is iron deficient, you will not start iron on day 1. Why?
It will release
That
free.
is,
So we don't start iron on day 1. There will be no improvement in iron, sir. Only the stores get replenished. So
that holds good even after 2 weeks, right?
yes.
So what happens in the first 2 weeks? Why are we not, even though we know pretty well that this baby is iron deficient, we will not give on day 1. We'll start only by around 2 weeks of life. Why is that so? Yeah, because the baby is not growing, and if you give at that point of time iron, then there will be a lot of free iron. Free iron is toxic actually. Free iron will facilitate some many organisms, and it will increase incidence of sepsis. So you have to establish a weight gain before starting all those things. That is the same concept, literally the same concept here. We usually will start at around 2 to 4 weeks, and for term babies, we can take some more time. Usually it is given at 4 to 6 months. You can take even more time actually. That's not routinely given. Only for these very low birth weight and preterm babies, we need to give. Okay. So this being a very preterm baby, what is the gestational age?
32 weeks, sir.
So what do you call this as? How will you classify this preterm?
Moderate preterm, sir.
What do you mean by moderate preterm?
Less than 28 weeks is very preterm. Extreme preterm, sorry, less than 28 weeks is extreme preterm. 28, 31 plus 6 is very preterm. 32
Okay.
plus 36 plus 6 is moderate preterm. Moderate preterm we can classify as early moderate and late moderate. Early moderate is 32 to 34 and late moderate is 34 plus 1 to 36 plus 6.
Okay, moderate preterm and late preterm is the standard classification. 32 and 33 we call it as moderate. 34, 35 and 36 weeks we call it as late preterm. So this baby is a moderate preterm baby.
Yes, sir.
Okay. So while you are presenting these type of cases, actually, when do you think the problem has started
Which problems?
for this baby? Currently, what are the problems you are treating? When has the problem started?
The baby was delivered by LSCS. The child had respiratory distress at birth. The
Okay, you
child,
think the problem started at birth?
yes, sir. The child
It's
was
not antenatal.
antenatally, the mother had PPROM. So
Exactly, that's the precise thing that I wanted to convey actually.
Yes.
So you are dealing with a sick baby now.
Yes.
The problem seemed to start from the antenatal period. So for these babies, actually, it's a good thing to start from the antenatal period. That gives a better chronology of the problem and of the sequences of all the problems and events that are going to happen. That will give an overall better picture than the present illness. Now, I don't know what really I have to look in this present illness unless I know the background of this baby. So the background of the baby is better delineated by telling all those things. Okay, that's what you started in the next slide. Actually, go to the next slide. Okay. Okay. You tell about the antenatal history. Yeah, please proceed. So what is this BMI? What do you want to know the BMI of mother?
With any obesity is there.
So rather than the mother height and weight, what else we are usually talking in antenatal period for weight in mother?
Waist circumference.
No.
Waist
Weight per se, this is a pre-pregnancy, right? Or at the time of delivery?
This is pre-pregnancy weight, sir.
Okay. What is her weight at the time of delivery?
She was 66, sir.
What is your comment on that?
Weight gain during pregnancy, it is about 8 kgs, sir.
No, what is your comment on that? That's the data. Interpret that data.
Adequate weight gain is about 8 to 12 kgs, sir.
That is for term gestation, right? This baby is delivered at 32 weeks, right?
32.
For 32 weeks, is there anything that you can look at and try to compare and see and tell whether it is adequate or not? Okay. First of all, that data 8 to 12 itself is wrong for a term baby. Usually there will be 12 to 15. Minimum of 12 kgs we expect actually during the term pregnancy. Okay. Nowadays there are standard charts available for antenatal weight gain during pregnancy, what we call as the intergrowth charts. So those will give a precise estimate of how much is the weight gain, whether it is adequate or not. So for this baby, it will be adequate actually. Okay. And BMI, what will you expect in a obese mother? What will you expect in a lean mother? How will be the weight gain during pregnancy?
Obese mother will gain less weight compared to lean mothers.
Exactly. So that chart is applicable only for a normal BMI mother. Very good answer. Yeah. So obese mother will gain less.
Yes.
Undernourished mother will gain more than what is expected. Good. Right. Yeah, please proceed. Okay, married since 11 years. Obstetric code, I think you are covering in later slides. Okay, we will discuss at that time. Okay.
Age at marriage is about 19 years and mother's blood group is O positive. Antenatal history. Gravida 1. It was a spontaneous conception. At 8 months of marriage, it was confirmed by urine pregnancy test done at 2 months of amenorrhea. There was history of bleeding PV at 3rd month of gestation. Ultrasound was done, which showed no cardiac activities, indicates spontaneous abortion. MTP was done at Ambur Private Hospital. Gravida 2 is a spontaneous conception after 7 months of.
Has this Gravida 1 has got anything relevant with our present preterm?
Spontaneous abortion has occurred, sir. Previous pregnancy was preterm.
Yeah, 2 months amenorrhea, if 2 to 3 months, if they have gone in for abortion, what is your take on that? What is the likely cause?
Chromosomal anomalies or
which has nothing to do with the present baby. Okay, right, good. Next.
Any infections, sir?
Yeah, that's fine. Okay, Gravida 2, what is happening? Okay.
Gravida 2, spontaneous conception after 7 months of previous miscarriage, which is also confirmed by UPT at 2 months of amenorrhea. The mother had history of pain and bleeding PV at 3rd month of gestation. following which USG showed no cardiac activity and spontaneous abortion was done. DNC was done at Vellore
Find
GH.
it. So both are spontaneous preterm at 3 months. Okay, next.
Gravida 3, it is a spontaneous conception after 6 months of previous miscarriage, confirmed by UPT at 2 months of amenorrhea.
I
Dating
think having said the interpregnancy interval, what it should be ideally?
at least 2 years, sir.
At least 2 years. Okay.
1.5 to 2 years.
No. You are reducing even further. 2 years itself is concerning for me. No, you have to give exclusive breastfeeding for 2 years, right? That is a norm. After that, only she is supposed to conceive. So it should be somewhere around 3 years minimum.
3 years.
Okay,
Yeah,
sir.
3 years should be the minimum actually. That is the ideal time. And 5 years is the upper cutoff. More than 5 years also, there is, they say, is slightly increased. So 3 to 5 years is the optimal. So you want a minimum of 3 years. Yeah. Proceed, please. Yeah.
Mother was given IM injection once in 15 days for about 4 months and was started on oral tablets for from 4th month of gestation to 8th month, probably progesterone.
The dating scan you have mentioned as was normal.
Yes,
So dating scan was, why the dating scan is being done? What is your interpretation on dating scan?
intrauterine or extrauterine conception we can confirm with dating scans, sir.
Why it is called dating scan?
EDD is calculated accurately with the help of dating scans.
Yeah, so you are supposed to count on the date in a dating scan. Why are you counting on other things? That is why it is called dating scan, right? So normal doesn't mean anything in a dating scan. What you are supposed to say is that dating scan corresponds with your LMP-ED or not.
Okay.
If not, they would have corrected and given a scan ED.
Okay,
So
sir.
what is the best estimate of gestational age? What are the various estimates of gestational age that you know?
Dating scan gives the best predictive estimate of this.
Okay, what is the order of prediction? For dating scan means dating scan taken at what gestational age?
First trimester dating scan, sir. Or yearly,
Specifically, yeah, early.
8 to 10 weeks of 8 to 12 weeks of gestational age. First trimester predicts yearly, or yearly second trimester scan that gives a
Yeah.
variation
The
of
first best estimate is 8 to 14 weeks CRL.
okay.
CRL is?
round.
Exactly. So 8 to 14 weeks. Less than 8 weeks also has a very poor predictor. So 8 to 14 weeks CRL has the best. And again, we have standards, intergrowth standards for that, and we go by that. If that is not available, then the next best is?
Second trimester, yearly second trimester scan, sir.
Which means up to?
20 weeks.
20 weeks. Next best, other than that?
That is
Next comes LMP. LMP, even though if it is very accurate and mother says that she has not even a single missed day, it is still notoriously inaccurate for up to plus or minus 7 to 10 days. So our CRL has a very good prediction, plus or minus 3 days. So that is still the most best available. So here your 32 weeks estimation is by CRL or your LMP-ED?
30
Both
weeks.
are correlating with each other.
Yes, sir.
Okay, that is what you are supposed to mention in dating scan.
Okay,
And of
sir.
course, other things which you say are important, that is for obstetrician.
Okay.
Whether it is a single or not and all, it's very obvious now. We don't need to know about those details right now. Exactly. Okay.
Manikumar, please have your video on.
Yes, sir. Because it is consuming data, I just switch it off. Yes, sir. I'll just click it on. Yeah.
Thank you.
Yes, sir. Yeah, please proceed. Yeah.
Anomaly scan was normal. All the 3 trimesters were uneventful. No history of GDM, PAH,
And when is an anomaly scan done generally?
second trimester, sir. Around 18 to 22 weeks.
No, but third trimester it is better visible or second trimester the best for anomalies?
Anomaly scan is for second trimesters.
Yeah, that's fine. But third trimester, the baby is big and you should be in a position to better see the anomalies, right?
Yes.
No, it's not so. The question is just why third trimester scan is very poor in predicting anomalies. Even if you see in some third trimester scan, they would have specifically mentioned that this is a third trimester scan, anomalies cannot be ruled out to a reasonable extent. That is one caution that will be written in some of the scans, if you have noted carefully. Why is that so? Okay, the relative proportion of Leica is very important. Leica provides a medium for visualization of all the organs. At second trimester only, it is very optimally seen. Third trimester, because of relatively less Leica, it's very difficult to see. Yeah, proceed, please. Yeah.
No history of
Okay. Dr.
GDM.
Priya,
Yes, sir.
both the mentors is delivering the answer from your mouth. So don't worry. You're presenting well.
Okay, sir.
Good. Continue.
Just keep going.
Okay, sir. No history of GDM, PAH,
Yeah,
hypothyroid.
please continue.
No history of fever with rashes. Mother's weight gain during pregnancy was about 10 kgs. Baby was
This,
delivered at...
here, you could have divided into first trimester, second trimester, third trimester. Okay.
Okay.
So, right. That would have been apt.
No, but this is for Gravida 3, sir.
Gravida
Actually,
3,
she has not come to the
Gravida
present at
5.
all.
Okay,
Actually,
okay, sir.
yeah, you can keep it as short as possible. These things, yeah.
Okay,
Gravida
okay.
3, yeah, 37 weeks LSAS, okay.
Baby was delivered at 37 weeks of gestation by emergency LSCS in view of fetal distress at Apollo Hospital, Vellore. Birth weight was around 3.4.
In view of fetal distress is vague, but can you just throw some more light into it?
The mother knows only for fetal distress, they operated the child. So that was the history I elicited from the mother.
Who is the distress matters? The fetus or the
Fetal.
obstetrician? That matters. That is what I'm trying to get the answer from you.
At 37 weeker, 3.45 kg. What is your comment on that?
It will be large for gestational age, so
Yeah.
probably they would have taken. So
Okay. Good.
it is.
Thank you.
It was an alive and healthy baby and no history of NICU admission or neonatal jaundice.
What do you call 37 weeks of?
Term babies.
Is there any subclassification of term gestation?
Yearly term, full term, post term, sir. Yearly term
Excellent. What do you mean by early term?
yearly term is 37 to 38 plus 6.
Very good.
Full term is
Please
39
proceed.
to 41 plus 6. Post term is more than 42.
Excellent. Good. Proceed.
No near term.
Is it?
Yeah.
Slide is not moving.
Go ahead. Please go ahead.
Yeah, please, please.
The slide is not moving actually.
Not moving.
Close it and come back. No.
Now it's
Yeah.
Yeah.
No, you're moving
moving
forward.
for us.
It's
You're moving
Gravida
forward.
4. She conceived spontaneously after 2 years of previous pregnancy. The pregnancy was confirmed by UPT at 2 months of amenorrhea. Dating scan was done. At 5 months of gestation, mother noted bleeding PV, advised 4 months of bed rest. She delivered a normal term baby at 38 weeks of gestation by LSCS at Vellore GH. The baby cried immediately after birth. No history of NICU admission, no history of neonatal jaundice. At 4 months of life, the child had complaints of fever with jaundice for 3 days. It was admitted at Vellore GH. Child was treated for 2 days. Treatment details not known and was declared dead on second day of admission.
What do you think this is? A previous baby has died at 4 months. What do you think this is?
Probably any fever with jaundice, obstructive jaundice, something.
Fever with jaundice. You're thinking in terms of obstructive jaundice, okay?
Leptospirosis.
No, until 4 months of 4 months of life, the child could have had a contact, like see, for every 6 weeks and 10 weeks and 14 weeks. During that time, any complaint from the mother, although you say that details not known, but the thing is that every mother who is very brilliant, more than us, I think they're very curious and cautious to know. Is it not? For first 3 contacts, the baby, about how was the baby, all those things, I think you can elicit some more details.
Okay.
And just suddenly 4 months of life, the child, fever, how many days, and jaundice, how many days, what investigation done, admitted, of course, yes. But during that stay for 2 days, what was done, what treatment was given, so that will probably give us some more light into the probable etiology as well as the cause, isn't it? It is not happening in a PHC or anywhere. It was happening in a teaching hospital. See, when you say GH, I believe it is a government medical college hospital, right, Manikumar sir?
Yes, sir. Yes, sir. Yeah. So here the precise question is the baby normal till 4 months of life?
Yes, sir. The mother didn't have any issues with the baby till 4 months of life. Sir.
No apparent symptoms doesn't mean normal. Can I get some more supportive evidence to say that the baby is normal at 4 months of life? What can you ask easily?
Developmentally normal.
Development okay. Weight is
vaccinations
growth is okay, right? No, how is the growth at 4 months? What is the birth weight? What is that at 4 months? You are thinking in terms of fever with jaundice, and if you think in terms of liver cell failure, the baby is unlikely to have a very good growth.
Yes.
Baby should have been very grossly undernourished, right? So what
Yes.
is the weight at that point of time?
She actually doesn't remember the weight at birth and weight at this.
Okay, so when you think in terms of a primary liver problem which has caused death within 2 days of presentation, what do you call this failure as?
Acute liver failure.
No. How do you classify liver failure? Acute. What do you mean by acute? What is subacute? What is fulminant?
Acute.
What do you mean by fulminant? Okay, it's very too early to predict so, but still we will think more in terms of some other febrile illness causing death rather than jaundice as a reason for death. All I could interpret is that if the baby is otherwise having a good growth and development at 4 months, we'll think it's more in terms of a febrile illness causing death at 4 months of life. What else you want to know in this scenario?
This is the catch point.
Any infection related you have to think about, sir. Hepatitis.
Somebody is asking a very good question actually. Any verbal autopsy done for that actually? Yeah. What do you mean by a verbal autopsy?
Identifying the cause of the death.
What do you mean by verbal autopsy? When it is done? Okay, there are some government guidelines for all infant deaths. For each and every infant death, there will be a verbal autopsy that is being done at various levels. The primary person who has been taken care of from the antenatal period will give a report. The treating physician will also generate a report. And there is a format, scheduled structured format for that to identify the etiology of all those things. Infant death is considered as a national, it's a prestige issue for a nation. So it is being dealt with very severely actually, and a lot of time and energy is being invested to find the etiology and try to find out ways to sort it out. So that is being conducted. That is being done for every baby. It's not for some babies actually, it's being done for all infant deaths. And now it is being extended till child deaths up to 5 years of age. Okay, fine. No, all I wanted to understand is that any febrile illness causing death at 4 months is very unlikely in an exclusively breastfed child. So all I want to know is that whether the baby is being exclusively breastfed again or not. Okay.
Manikumar sir is going to collectors meeting on every month.
Yes.
For that, in fact. To explain about, to find the cause of an infant death, if at all, if it happens in our district.
Yeah.
So you must know.
Yeah, it's not only for government college deaths, it's for all infant deaths, even if it happens in a private institution. All of them will be asked to attend that meeting actually. Yeah. Yeah, please proceed, Dr. Priya. Yeah.
Gravida 5 is a present pregnancy. First time.
What I understood from this presentation is, here is a clue that the baby was all right, apparently well, feeding well, gaining weight. There is no growth faltering. And at 4 months of life, suddenly developed fever 2 days with jaundice and died.
Yes.
So here is the catch point. I think this will probably give some clue. Let us see. Next. Okay, for the discussion part, I think when we come, probably we can discuss more about that. Okay, go ahead.
Gravida 5 is present pregnancy. First trimester, mother's age at conception is about 30 years. Spontaneous conception after 5 years of last delivery. Her LMP was 1/8/2024. EDD was 8/5/2025. It was confirmed by urine pregnancy test at 2 months of amenorrhea. She was booked at SMCH. Periconception of folic acid was not taken. No history of excessive vomiting, fever with rash, drug intake, radiation exposure, and dating scan was done on 3/5/2025.
Why she was not taken? Because was she reluctant, fed up of taking any medication? Because having,
She was prescribed, sir, but she didn't take, sir. She didn't.
we must also know why she was not taken. He's not keen. She is not fond of the color. Having known the crux of the situation, why she has not taken? Is it
I
not?
think these are standard questions. What do you mean by periconceptional folic acid?
Before conception, for 3 months,
Why should she
plan-
take it before conception?
already 3 pregnancy losses are there, sir. So folic acid.
No. Periconceptional folic acid, for that matter, is advised for all pregnancies, not for only high-risk pregnancies, actually. Okay. So for high risk of, what is it going to prevent?
Neural tube defects.
No, why do you want to take it before conception? Why not after confirming pregnancy?
Early weeks of gestation only maximal brain growth happens, sir. So
Comes to
maybe
the very
unaware that
basic
she is
question.
pregnant, sir.
When can you confirm pregnancy at the earliest?
42 days UPT.
Okay, 35 days generally, after 5 days after a missed period generally, okay. So when is the problem happening in a primary neural tube defect? Or when does the anterior neuropore closes and when does the posterior neuropore closes? Okay, that typically happens at around 23rd and 27th day. So by the time you confirm pregnancy, by whatever means you have, already the problem has happened. That is the problem and with the neural tube defect, and that's why we are advising periconceptional. Before you confirm your pregnancy, or rather, when do you know is that when you plan for a pregnancy, you have to take folic acid. Okay.
This
Please
is also
proceed.
called as dating pill.
Yeah.
So just like dating scan, it's a dating pill. Once the
Okay.
marriage date is confirmed, you are supposed to take it.
Now, is the government giving iron and folic acid tablet for all during pregnancy?
Yes, sir.
Why is that folic acid given during pregnancy and not preconceptional? What is the role of that?
Stores will be adequate till the numbers. So
Water soluble vitamins, you expect some stores to happen in the body. Only for fat soluble vitamins we have stores. Water soluble, your diet has to be perfect throughout. Very minimal stores if at all. Okay.
Have you got the app downloaded in your mobile? AMB, Anemia Mukt Bharat.
That is a government program which is going on. Okay. Okay.
Okay,
Fine.
go
Then.
ahead,
So
please.
that folic acid has some other benefits. The folic acid which is given during pregnancy increases the birth weight of the baby. It is an attempt to reduce low birth weight in the community. That has different role. Periconceptional folic acid has different role. This is given for some other role. For mother, of course, calmness causes dimorphic anemia. That improves that also. But for the baby, it increases the birth weight also. Yeah, please proceed, Karen.
second trimester, quickening was felt at 5 months of gestation. Iron and folic acid tablets were taken for 2 months. 2 doses of TD was given. No history of hypothyroidism, GDM, PAH. No history of bleeding PV. Anomaly scan was done at 22 weeks and it was reported to be normal.
Any comment on the second dose of TD vaccine? What is the current recommendation?
More than 5 years gap means we can give it second dose.
What is the vaccine that can be given ideally?
Tdap.
Okay, good.
Is there any organization which recommends anything else? Just like IAP, the obstetric and gynecology have an organization, isn't it? What they recommend?
Any
They
other
recommend
vaccines that
Tdap.
can be considered? Okay,
They recommend Tdap. Okay, go ahead, please.
please.
Third trimester, she continued to perceive fetal movements well. Growth scans were normal. No history of abdominal pain, UTI, bleeding PV. At 30 weeks plus 5 days of gestation, mother was admitted with complaints of leaking PV and was treated with IV antibiotics for 7 days and 4 doses of IM injection was given for fetal lung maturity. Pre-pregnancy weight was around 56 kgs and weight gain during pregnancy was around 11 kgs.
What is this called as? Leaking PV and was. What do you mean by that? Leaking PV?
Rupture of membranes, premature rupture of membranes, preterm premature rupture.
What is preterm? What is premature?
Less than 37 weeks, if the membrane ruptures, then it is called as preterm rupture of membranes.
Okay, premature means?
Actually, the term has changed as preterm pre-labor rupture of membranes. Pre-labor is before the onset of labor.
Exactly. Good. Okay. So PPRM, the baby was treated with IV antibiotics for 7 days and 4 doses of IM injection. What do you mean by that?
Steroids was given, sir, dexamethasone.
Okay. How much is given?
6 mg, 12th hourly apart, 4 doses.
Okay. What are the benefits of steroids?
It prevents RDS.
Okay. Any other uses of it? Than RDS, respiratory distress
NEC.
syndrome, it reduces.
It
Anything else?
prevents NEC.
Okay.
ROP also.
Okay. NEC also it reduces. IVH, intraventricular hemorrhage, it reduces. That is one of the most important use of it actually. Okay. Fine, right. Weight gain during pregnancy, 11 kg. Okay, good.
Natal history. The scan EDD was 8/5/2025. On 13th of March, mother was admitted with complaints of leak in PV and abdominal.
Preferably while telling these histories, it's always better if you say at what gestational age. We can't keep in track of the dates and we can't calculate. Instead of saying on 13th March or 10 weeks of gestation, if you say it's better. Yeah.
On 32 weeks of gestation, mother was admitted with complaints of leak in PV and abdominal pain since 11 p.m. in SMCH. She delivered a alive male baby of birth weight 1950 by emergency LSCS in view of preterm pre-labor rupture of membranes with fetal distress at 14/3/24 1 p.m. at around 32 weeks plus 1 day of gestational age. Baby did not cry at.
What do you mean by fetal distress?
The child's heart rate was dropping. So.
No, were they attempting normal delivery earlier?
No, sir. Previous LSCS was there, so they attempted for LSCS in this with scar rupture, impending scar rupture.
No, that baby was that mother was previously admitted. How long ago for that steroids?
11 days ago, sir.
Okay. After 11 days, do you want to repeat a steroid course or what is your take on that?
A repeat dose of steroids is indicated if the mother is less than 34 weeks of gestation and she's expected to deliver in less than 7 days.
Precisely that was. 11 days ago, the baby was given, the mother was given a dose of antenatal dexa. And now again, she came with PPRM, which indicates that she is going to deliver imminently.
Yes.
So this will be a indication for steroid repeat dose, or you can just wait and watch.
Last 7 days, it's okay. According to RCOG, last 14 days, it's okay.
Okay. So here it was given or not?
No, sir. She didn't have any seconds.
Okay.
It's happening in the same hospital or different hospital?
Same hospitals.
Okay. They didn't have that in their mind to give it. Is it? What is your comment? No time. Okay. Okay. Baby did not cry. What was done?
Baby was given 2 cycles of PPV, sir. Then child was intubated and transferred with the transfer incubator to the NICU, where the child had received 1 dose of surfactant, sir.
No, before that, why did the baby not cry at birth? Given the optimal conditions, how could you prevent this? This baby is already having a very huge mobility by delivering at 32 weeks.
Yes.
So here the baby is also asphyxiated. So what is the reason for this and what could have prevented this?
Respiratory distress syndrome.
So how long is the leaking PV duration?
11 hours, sir.
Okay. So they must have come to the hospital immediately, right? With leaking PV, nobody will stay in hospital. Nobody will stay in home.
Yes.
They will immediately come to hospital. What happened in that 11 hours?
How
Around
the
5
baby
a.m.
monitored?
The mother
What
came to the
monitoring? Remember about monitoring?
NST was done, sir. They and the
32 weeks, you want to rely upon NST for fetal well-being. Okay. You can to some extent, okay.
and she was delivered at around 1 p.m. sir.
The previous delivery is LSCS, right?
Yes, sir.
Previous 2 deliveries.
Yes, sir. Previous 2 deliveries, one was they declared better, one was normal.
So they are contemplating a normal vaginal delivery for this baby. They have made a decision not to give steroids. And they are trying for normal delivery, and in due course, the baby developed fetal distress and was delivered by emergency LSCS. Is that a history?
Yes, sir.
I think this is what we'll have to take it into.
Okay.
Exactly, you are reading the mind of the physician being close with them.
Okay. Yeah. So those are important details to assess what is happening. Okay. Immediately after the baby, what are the things that you will make sure in the delivery room? This is a 32-weeker baby who
Consider
has not
it
cried
to
at
be a
birth.
preterm delivery. The delivery room temperature should be optimal. We should keep
When compared
delivery
with
room-
the term delivery, for a preterm delivery, what other extra precautions that you will be taking care of? Thermoregulation is applies for a term baby also.
Yes, sir. Plastic wraps, head caps can
Very
be
good.
heated
Excellent.
mattress,
Okay.
preheat
Mattress, some other thing, extra measures to prevent hypothermia. Okay. Point well taken. Okay. And this baby is asphyxiated at birth. What is the most important thing that you should need here?
delivery room CPAP, sir. It was kept ready.
How will you keep delivery room CPAP? How will you give delivery room CPAP?
Minimum pressures of about 5 centimeter at
No.
room.
What apparatus or what equipment you
TPs,
need?
new puppy.
Okay. So you need a TP's resuscitator. That is what is recommended for all preterm babies less than
32 weeks.
Okay, so here the target should be not even a single breath without CPAP or PEEP. That is the target, literally.
Yes.
So what is the advantage of this early CPAP in these babies?
It will prevent the need for surfactants, sir, and the prolonged
Okay.
incubation stay and oxygen requirement.
Okay, so was this baby given any TP's resuscitator?
The 2 cycles of PPV was given, sir. The baby was apneic.
Okay. When compared to the term baby, what is the difference in resuscitation in a preterm baby?
100% was being given before it.
No. For preterm baby, you start with 100% oxygen.
Delivery room oxygen, sir. 21% FaO2 will take.
No, that is for more than 35 weeks. For less than 35 weeks, you start with Okay, NRP is one of the widely researched area actually. Here we have few doubts actually. Okay, here to start with somewhere around 21 to 30. There's a starting initial FiO2, and what will you titrate that based on?
Based on the
How will you titrate your FiO2 requirement? You start with 21 to 30%. You give what do you need to give 30% oxygen? What equipment you need to give 30% oxygen?
PP, self bag and mask.
Okay, if you go and practice in any center outside, what equipment you need to give 30% oxygen?
O2 blender.
Exactly. What do you mean by a blender? Blender combines air and oxygen and it will give the appropriate percentage of your expected FiO2. So you need a blender. Many of the times it may not be available. So if it is not available, you just don't connect a reservoir to your bag and just give it. Even if you don't have a TPs, you still can expect some lower FiO2. So how will you titrate your FiO2 requirement? You start with 21 to 30 and you continue at 30, or how will you titrate?
If the FiO2 requirement is more than 30% to maintain the saturation of more than 90%.
Your target saturation is 90%.
Yes. Minute variation is there, sir.
Exactly. Yeah. So based on your target saturation, what are those called as? Those are based on Dawson's nomograms. So based on those Dawson's nomogram, you have a time-specific saturation targets. So can you say roughly what it will be the saturation target at somewhere at around 1 minute
1
of life?
minute, 60 to 65.
Exactly, 65% you don't just panicky.
Yes.
That is the one expected at 1 minute of life. You can't target 90% at that time. That's one of the commonest error which is being done actually. What is the problem of giving excess oxygen?
A retinopathy of prematurity.
Okay, not only that, many oxygen-free radical
Free radicals.
diseases of newborn. That's what they say. It forms a cluster of diseases. Many of those diseases are actually increased by giving so. Okay, so you'll be worried about your pressure. You'll be worried about your FiO2. You'll take care of your extra precautions to prevent hypothermia. All these are very essential in a preterm baby. Okay. Then what happened? Okay.
The baby was on O2 support in view of respiratory distress. In view of persistent respiratory distress, baby was treated
No,
with
this is happening in delivery room. How was the baby shifted to the
in
NICU?
transport incubators after intubation.
Okay. So what will you do usually? Generally, we target within 15 minutes to 20 minutes of life. We target the baby to be shifted in level 3.
Yes.
Okay. So what is the admission temperature to NICU? How does it influence your outcome?
Admission temperature is it prevents the
The magnitude is very huge. All I want to emphasize is that for each and every drop in temperature, your mortality increases by nearly 20%. And for these preterm babies, it increases by nearly 33%. The impact is very huge. Okay. Fine, please proceed. Okay.
the baby was treated with drugs for lung maturation within 2 hours of birth, as informed to mother. The baby was continued on O2 support till 9 days of life and was weaned off to room.
What do you mean by the drugs for lung maturation?
Surfactants.
So when do you have to give?
As early as possible within 2 hours of life, sir.
How will you give? What is that 2 hours called as?
Curosurf and Servanta 2 are there, but here the child received Servanta. So Servanta dose is 100 mg per kg.
No, I'm not talking about the type of surfactant that is given.
Okay.
When will you give surfactant? What are the indications for giving surfactant?
When the CPAP, when the mean airway pressure is more than 7 centimeter and CPAP requirement is more than 6, and the FiO2 requirement is more than 30 to maintain the saturation of 90%, then we'll give surfactant, early surfactants.
Okay, more than 6 or more than 30 is the European consensus guidelines, which is routinely being followed in many of the units and which NNF has also adapted. Okay, so when you decide to give surfactant, how will you give surfactant?
There are 2 techniques, Lisa and Ensure, and we gave it Ensure.
Now, what is Ensure? What is Lisa?
Lisa is less invasive surfactant administration. Ensure is intubation, surfactant, and extubation, sir.
How will you give less invasively?
Via NG tube will gives.
Okay, via vascular catheter, the commonly available thing is NG tube. Okay, that's fine. Via straight catheter. How will you introduce that into the trachea? Do you need any special equipments to introduce, or just like that you can intubate and give it, or during Lisa?
Have you ever administered in your unit?
Yes, sir.
Okay.
Okay, very good. Okay. Find it. Okay. Yeah, what do you do in Ensure? You intubate the baby, you give surfactant and
extubate, sir.
Extubate within?
Sir?
Extubate within? Immediately after giving surfactant, you extubate.
Yes.
Okay. So what is the problem of giving surfactant, Servanta versus Curosurf? What are the advantages or disadvantages?
Pulmonary hemorrhage can occur, sir. With
No, those things are relatively fairly okay. The volume is more in Servanta, 4 ml per kg you have to give. So what you can expect?
air leak.
Not air leak. It can cause some airway block because of the huge volume. You have to make some extra measures to make sure that the surfactant gets dissipated. That is one problem. And Curosurf, you can give a huge dose with a smaller volume. That's a great advantage of it. Okay. but that is costly. Fine, right? So still, Savanta is available in government setup and it's perfectly fine. Okay. Okay. So what do you mean by in-rec-sure rather than insure?
Recruitment of lung,
What do you mean by recruitment?
alveolar recruitments.
What do you mean by recruitment? How do I know that
Mm,
recruitment has
valve
happened?
so that adequate gas exchange happens.
So how do I know that alveolar recruitment is complete?
Rise in saturation, MAP is decreasing,
Okay.
SpO2
So that is
requirement.
the only important thing that you should know in case of ventilating RDS. The strategy is open lung ventilation. What do you mean by open lung strategy? You have to open up all the alveoli. So how do you know that you have opened up all the alveoli? Is that your FIO to recommend clinically should be less than 25% to 30%, and baby should be otherwise comfortable. If your FIO to recommend is still at 70%, 80%, it means that you are giving inadequate pressures and getting a normal saturation. That's not good for a baby.
Okay.
So you have to open up all the alveoli. So how will you find the severity of respiratory distress? How will you grade the respiratory distress severity?
Depending upon the requirement of subsequent doses.
No, how will you clinically grade the respiratory distress severity?
SAS score, Silverman Anderson score.
What do you mean by that score? What are the components?
Xiphoid retraction,
Okay.
upper sternal retraction, low upper intercostal retraction, lower intercostal retraction, grunting, and cyanosis.
You're partly right, and of course, if somebody is there, can they tell what she is telling wrong? What do you mean by upper chest? What do you mean by lower chest?
Supraclavicular retractions. Lower chest is intercostal retractions, of
No,
course.
below what you call it as upper, and above what you call it as upper? What do you mean by upper chest and lower chest in your Silverman Anderson scoring? Okay, upper chest is when you see the baby from the sidewards. You draw a mid-axillary line, and whatever is above that mid-axillary line, you call it as upper chest. Upper chest, you won't grade based on the retraction. You will call it as lag with inspiration. You compare abdomen and upper chest, and which is lagging you based on, and you score based on that. What you call as upper chest. It's not as you say upper chest intercostal, nothing like that. Lower chest is, of course, that you find the extent till what it extends. Another two are right, of course, grunt and your FIO to recommend. Okay. Okay. Nasal flare. Yeah.
The baby was started on IV medication from day 1 to day 5. Started on phototherapy on day 2 of life and continued for 48 hours and stopped. Started on KMC on day 2 of life for 10 to
I
12.
just need some more data on this. Actually, this baby is delivered after PPRM, right?
Yes, sir.
Okay. So will you start antibiotics on day 1?
Yes, sir. Risk of sepsis was there, so we started on antibiotics, sir.
So when do you start antibiotic prophylactically? When do you wait for symptoms? When do you screen and start?
If there is more than 3 risk factors are there, preterm rupture of membranes or foul smell in liquor, unconfirmed intrauterine infection and inflammation, spontaneous onset of labor without rupture of membranes, or prolonged duration of labor for more than 12 hours. If
Okay,
the
that was
more
the
than these
concept
factors-
which we started. There are various approaches in your early onset sepsis. So
Okay.
this is what we started over a very this was an old concept actually. Just count the number of risk factors. 3 you start, 2 you screen, 1 you hit and watch. So that was a very old concept. Okay. Is there any other thing that has been evolved right now? Okay, we try to classify the symptoms actually, and we try to add a clinical monitoring of babies. That's what is being nowadays. It's being endorsed by NNF also actually. So don't just count the number of symptoms. You can use a sepsis risk calculator. In some population, it is found to increase, but of course, you need some JBS data screening, and it's very difficult to put. So instead of using that, you just classify them as yellow risk factors and red risk factors. If red risk factors are there, you just give it. Yellow risk factors, you just wait and watch and continuously monitor the baby for these more than 32 weeks. Less than 32 weeks, even if there is anything, we will like to start antibiotics. So this baby PPRM is the only risk factor, right?
Yes.
Nothing else, right?
And resuscitation at birth was done.
Okay. Fine, right? Okay. And when will you stop antibiotics?
Culture negative, we'll start at 5 days. If culture is positive, we'll continue for 14 days. And there
And
is
can you get a culture negative report?
at least a 72 hours growth we can get, sir, at the earliest.
Okay. How much blood you should take for culture?
1 ml of blood for 5 ml of culture growth.
Okay. Irrespective of the culture method used, or?
For bactec, we'll use this.
Okay. For bactec, there are special neonatal bottles. You can't get a pediatric or adult bottle because they contain a large amount of volume of broth. Ultimately, it comes to a matter of your ratio of blood is to the total volume of the broth. So if you take a larger volume, you can't afford to get that in a preterm baby. And in these preterm babies, taking blood sample is one of the commonest cause of anemia prematurity, right? So what are the ways to prevent anemia in the preterm baby?
Less frequent sampling.
Okay, that's the foremost thing. Iatrogenic blood loss is the commonest cause. You got it right. Okay, anything else? What else you can do? These are the things that are covered in what Sir has asked, Anemia Mukt Bharat, right? So those are the guidelines that are given for all those things. Any other thing that you can easily do to prevent this? Reduce your sampling, okay. And if at all you need sampling, go for micro sampling techniques rather than macro sampling techniques. Okay, then? Perinatal period, immediately after the baby is born. Single
That
most
cord
important
clamping anyway
intervention.
helps.
Exactly.
That's what Sir is trying to ask you. You have not told anything about that.
Cord clamping. Is there anything on what do you mean by delayed?
Preterm at least 30 seconds we'll the term babies 1 to 3 minutes we can leave for delayed cord clamp.
30 to 60 seconds is the recommendation. In India, we advise at least 30 seconds, at least 60 seconds. Even if you give up to 3 minutes, it's good actually. What are the benefits of delayed cord clamping?
Circulatory volume will improve.
Roughly by how much? What is the circulating volume in a baby? Roughly, what is the blood volume in a baby?
80 ml per kg.
Very good. Okay. How much will you think it is increased by doing delayed cord clamping? Okay, 30 to 35 ml per kg. That's a huge amount. You can see how much is the blood volume and how much it is increased. So what are the advantages of that? So one is that it reduces anemia. Any other advantage of that?
Hemodynamic stability, it improves circulatory.
Exactly. Hemodynamic stability is improved, and for these very preterm babies, it's extremely important. These babies are at risk of your vasomotor instability to a greater extent. That is reduced to a greater extent by that. Okay, very good. Then. Okay, because it gives a large amount of white blood cells also, it reduces the risk of infection to a greater extent. That is also reduced, and there are numerous other advantages. It improves the neurodevelopmental outcome and reduces the mortality and reduces the risk of even thermal regulation is also better actually. So there are many advantages of that. Okay, then fine. Proceed, please.
Yeah, Dr. Priya.
Yes, sir.
You mentioned as the baby was started at tube feeds within 1 hour.
Yes.
And started on palliative feeds. I would like to know, is it MOM feed or PDHM?
MOM, sir. We express from the mother.
What is the advantage of mother's own milk when compared with donor milk?
Donor milk will be mostly pasteurized. So most of the vital micronutrients will get lost.
Okay.
Mother's milk will have better micronutrients.
Okay. So what do you mean by cross donation of milk? A mother who is willing to donate her friend who is sitting in that hospital Can she donate directly without going through the process of milk bank and getting pasteurized and wasting all the nutrients? That is a defect, you say, right? But in
Yes.
cross donation, she can directly donate, right? That is better, right?
But we can't do
Why? What is the problem here? Of course, you are right. Okay, what is the problem?
unpasteurized milk. There is risk. Whether it is a term or preterm milk.
Okay.
This is a preterm child, so we can give only preterm milk.
Do donor human milk segregate as term and preterm? Okay, that is even in some large units they do segregate actually, but generally it is not being done. Generally, pasteurized donor human milk indicates that it's a pooled milk. What do you mean by pooled milk? Yes, sir. Sure. Okay. Okay, you get it from many mothers and pool it in a single litter and give
Pooled
it.
milk, yes.
Yeah. Okay. Proceed, please.
But from this started 2 feet in 1 hour, anything else you could probably save sepsis, the child? With the colostrum, you can.
Colostrum swab decreases the risk of NEC, sir.
That's good. That you have not mentioned about it, so I thought I'll ask you. But it's been practiced
Yes, sir. We
in your
practice.
center, is it? Okay. Right.
Okay.
No history of seizures, no history of lethargy, refusal of feeds, abdominal distension, no history of fever. The baby passed urine and meconium within 24 hours of life. Now the baby is on palliative feed and KMC care. The baby is breastfed on demand 8 to 10 times per day, 3 to 4 times at night. Duration of each feed is 20 to 40 minutes from one breast at a time. The baby sleeps around 2 to 3 hours after each feed, passes urine 6 to 8 times per day, and stools 3 to 4 times per day. Immunization history.
Why does the duration of feed matters?
Fore milk and hind milk, there is change, sir. Only if she breastfeeds for about 20 to 30 minutes in a single breast, she will get the fore milk and the hind milk. Fore milk is only water content, hind milk contains more proteins and other macronutrients.
Okay.
Hind milk is rich in fats, which will give you energy.
Which is weight
Yeah.
gain and helps in weight gain.
Okay.
Immunization history, BCG, OPV, and hepatitis B was given on day 1 of life. Thyroid screen was done, was normal. Baby
What is the birth weight of this baby?
1950.
Can you give hepatitis B?
More than 2 kgs we can weigh, but the baby.
Usually wait till the baby is set free of risk of BPD actually. Okay. Usually it is given at around 2 weeks of life. Okay, for these babies. Okay. Proceed.
Family history, father's age is
So
30.
is that, see, having a high risk, which you have narrated, but is that screening, TSH screening alone would suffice, or anything more it could have probably done for this baby? As far as the neonatal screening is concerned, I'm asking you.
BCT blood grouping here in on screen.
No fever, the baby earlier,
Hmm.
on 4th month, you have lost a baby, isn't it? So
Yes.
you would be more cautious about screening, what I would have missed. So what other screening would have probably helped you and you would ask for in this baby, in this?
Okay, any sudden deterioration in the baby also warrants a IEM screen actually. So we should be
Okay,
very
sir,
cautious.
there is a comment that we need
Yeah.
to go faster.
Yeah.
I think what's the
Please.
time, Prasanna? 9:30?
9 7.
Yes, sir.
Okay. Please carry on. Yeah.
Thank you, sir.
Family history, father's age is about 35 years and mother's age is 30 years. It is a non-consanguineous marriage. Socioeconomic history, both have completed high school education. They fall under modified Kupasamy scale, lower middle class. Summary, a baby is a moderate preterm 32 weeks male born out of emergency LSCS in view of PPROM with the risk of sepsis and a bad obstetric history in a mother of previous to abortion, with the respiratory distress treated distress syndrome treated with surfactant and with jaundice treated with phototherapy. And currently the child is on KMC care and palliative feeds.
More than the bad offsetting history, bad neonatal history in the previous baby is more important. Death.
Okay, sir.
Yeah. Okay. Fine. Proceed.
Examination. Baby was examined on day 7 of life. General examination. Pastor. The
Manikumar
baby,
sir, the jaundice part, I think left out. You have not discussed because
Yeah.
therapy started on second day of life.
Okay.
We would probably have the discussion later when she comes.
Okay, sir. Sure. Okay.
Posture. The baby is lying in a warmer with the flexion of both upper and lower limbs. Baby is awake, cry and activity fair. Color is pink, comfortable in room air, no pallor, icterus cyanosis. Vitals, temperature 37.2 degrees Celsius, peripheries are
No icterus is unlikely at this stage, right? So icterus will usually be present in these babies. It's only you have to decide whether it is significant or not. So till what level you expect at this age?
What?
What level means, so what do you mean by Kramer's rule?
Kramer's will be decide phase means 1 to 5, upper
Okay.
is 5 to 10, abdomen and upper thigh is 10 to 12, legs and arm it is 12 to 15.
So there is a cephalocaudal progression of jaundice. For what jaundice this happens?
Physiological jaundice.
Okay. Oh, no, what I want to emphasize is that for conjugated jaundice, you don't get this cephalocaudal progression.
Okay.
Only for unconjugated jaundice, you get this cephalocaudal progression.
Yes.
Conjugated jaundice, even if it is 2 to 3, you can even get it in the soles.
Yes, sir.
Doesn't mean anything.
That-
Okay. So this baby was treated with phototherapy on day 2 and now it has nearly disappeared.
Yes, sir.
Okay. What do you think is the cause?
Physiological jaundice.
Any jaundice
Phototherapy was
treated
given
with
for physiological
phototherapy
jaundice.
is not physiological. Yeah.
Mhm.
Any jaundice requiring phototherapy is pathological. So for a pathological jaundice, you are supposed to find the etiology. What do you think is the etiology here? What are the risk factors for jaundice that you can see in this baby?
Preterm is a risk factor.
Okay, very good. 32 weeks is the risk factor. Okay.
Okay, number 1.
The risk of sepsis was there, so it is not.
Okay. So precipitating factor.
Okay. Conjugated jaundice is more common in sepsis. Okay. What is the blood group of the mother?
O positive, sir. Both are O positive. Baby and the mother.
Okay. Okay. No, that I don't know. Okay. You had to say that. Okay. So no blood group incompatibility setting is here. Okay. This baby is delivered by emergency LSCS.
Yes.
Okay. No, for a day 2 jaundice, what are the commonest causes? Now, what do you think in terms of if the baby develops jaundice within 24 hours of life?
Pathological jaundice. Less than 24 hours is pathological jaundice.
That's fine. Okay, we presume it is pathological. It's your job is not over if you say it is pathological. You are supposed to say the etiology.
Extrahepatic biliary atresia, neonatal cholecystitis.
Oh my God. Okay. No, that's very rare. Okay. For day 1 jaundice, what do you think? For your kind information, extrahepatic biliary atresia doesn't manifest with jaundice during the first 2 weeks of life.
Okay.
It usually starts by only in the embryonic type, which is happening in the 15% of cases, 10 to 15%. You can have it in earlier onset. That is quite unlikely. Okay. Now I'm asking in the first 24 hours, if you see visible jaundice in a preterm baby, what do you think of?
Common causes.
Common causes. Yeah.
Volume restriction.
No. Less than 24 hours, onset of jaundice, even in a term baby, you have to consider it as hemolytic unless otherwise proved. You have to presume it is hemolytic jaundice.
Why you have a doubt about that, Priya?
Yeah.
Yes.
Less than 24 hours jaundice, you presume it is hemolytic. You need some extra evidence to prove me that it is not hemolytic if you are going to prove. Literally, for all jaundice, visible jaundice on day 1 is invariably taken as hemolytic. Hemolytic commonest causes are
ABO incompatibility, RH.
ABO.
ABO, RH, okay. Then?
D6PD deficiencies.
Yeah, those are relatively rare. Common will be these 2 things, okay. And minor blood group incompatibility and other things will come. And even some hereditary serocytosis or membrane defects can also come, okay. So unless otherwise proved, you have to presume it as hemolytic, less than 24 hours of the onset. Okay, physiological jaundice usually starts by day 2, but here you have given phototherapy, which confirms it is pathological. What are the commonest pathological causes for onset on day 2? Common things.
Increase production or increase destruction. Hemolysis.
No, you're going into the mechanisms. I'm a clinician. I need some clinical details actually. How will you differentiate or what causes you will think in terms of? Some other organized, jaundice comes from some blood, right? So wherever you get some hematomas, you will get that.
Certain
So what are the
hematoma or
okay?
carcinidum.
Caput is very
Inflammatory
unlikely here
bleach.
because directly they have taken for emergency LCS.
IV.
Cephalomyoma is also unlikely. Bruising can be there in case of malpresentation. Presenting part can be have some bruising in a preterm baby that can cause actually. So these are relatively common causes. And after 72 hours, if you have onset of jaundice, what is it likely to be? Common causes? What are the common causes?
Breastfeeding jaundice.
Okay, breastfeeding jaundice usually starts after 48 to 72 hours. Okay, what do you mean by breastfeeding jaundice?
Inadequate breastfeeding.
Okay.
Intrahepatic
So how will you find the adequacy of breastfeeding? That you had tell detail in the exam history. I liked it very much actually. Of course, you got all the points, and I'm totally convinced that this baby is feeding nicely. Okay. And after some 10 days or after 1 week to 2 weeks, if you have onset of jaundice, what do you think in terms of
breast milk jaundice.
breast milk jaundice prolonged? These are the common causes. To say roughly, these
Will
are
you,
common
will you
causes which you should
intervene
not miss.
breast milk jaundice with anything?
Sir?
What is your take on this breast milk jaundice?
The cause of breast milk jaundice, some factor that is present in breast milk that inhibits
What
the
factor?
beta glucuronidase or maternal progesterone that is.
Is not still clear.
Beta glucuronidase enzyme that breaks down the bilirubin and it increases the intrahepatic circulation and that is the cause.
So you need to interfere with anything, or you can just go ahead with that. Will it settle on its own?
Will
What is your
spontaneously
comment?
settle.
Yes.
No treatment is needed.
Most probably after 2 to 3 weeks, it will settle on its own. It will continue to breastfeed. That's all.
Yeah.
Okay. Right.
Okay.
And the respirate. Shall I continue?
Yeah, please.
Respiratory rate is 49 per minute, abdominothoracic type. SpO2 in right upper limb 97%, left lower limb 96%, left lower limb 97%, and right lower limb 97% with 27 or 21% FiO2 on CPAP. Pulse rate is 135 per minute in right brachial artery, regular in rhythm, no specific character, well felt in all peripheral pulses. BP was around 60 by 42, MAP of 50 in right upper limb. CRT is less than 30 seconds and peripheral pulses were well filled. Anthropometry, birth weight is 1950 gram, present weight is 1945 gram, length is 45 centimeter, head circumference 31 centimeter and weight gain on the 15 gram per kg.
Oh, what is the chart which you have shown on the right side?
Penton's chart.
Okay. Sure, okay, this being a 32-weeker baby, you prefer to use Fenton. Okay, more than 33 weeks, actually, we have standard charts.
21 shots.
It has got 21st chart, okay. So, how is the head circumference measured?
Most prominent site at the occipital.
What is the accuracy or precision? No, in other words, what I'm trying to ask is that if you can measure 31 centimeter, what is the next measure which you can take? Is it 31.1 or 31.5 or 32?
Plus or minus 0.3 centimeters.
0.3. That means you have not measured head circumference in your lifetime. Oh my God. Okay. So how do you had to have a head circumference tape, right?
Yes, sir.
So the accuracy is 1 millimeter.
1
So yeah, no, I'm surprised to see all those in whole numbers. Your length is also in whole number. Your head circumference also in whole number. Doesn't happen if you measure it correctly. Or even in that case, if you measured it exactly as 31 centimeter, you are supposed to document it as 31.0 centimeter. Though technically it is the same. It just means that you have seen up to that accuracy. You are just conveying to me that you are seeing to that accuracy. Yeah. Okay. Find it. Okay.
Head to foot examination, hair normal, AF open 3 into 3 centimeter and at level, no cephalohematoma, subgaleal bead, no facial dysmorphism, eyes and ears normal, oral cavity normal, no oral thrush, no cleft lip, no cleft palate.
Any other fontanelle? Open?
Posterior fontanelle opens.
Okay.
Neck
No
normal,
facial. No facial dysmorphism. What do you expect, if at all, any dysmorphism?
low set ears, mongoloids. Any
You suspect any enzyme deficiency? Thinking of the previous child who had a jaundice and died of.
Okay.
Any syndromic which you think of, if at all?
Gilbert.
Sure.
Preterm.
Mhm.
Okay. All right. Go ahead.
Neck normal, skin normal with sparse lanugo hair, limbs normal, IV cannula is present in the right foot. No divarication of recti, umbilical stump normal, no discharge erythema. Anal orifice normal, external genitalia, left undescended testis, spine normal, hips no DDs.
Antibiotics were stopped by day 5 and babies on full feeds by day 3, right?
Yes.
What is the need for IV cannula on day 7?
No. On
Okay.
the day of examination, the child was.
Yeah, you examined on day 7 and now it's day 11. Okay. Find it. Is the baby on caffeine?
Yes.
Okay. Caffeine you start prophylactically or the baby had apnea?
Post extubation less than 34 weeks, so we started on caffeines.
Okay. Find it. Okay.
Cardiovascular examination, no precordial bulge, apical impulse in left fourth intercostal space lateral to midclavicular line. S1 is to present, no murmur. Respiratory system, chest wall bilaterally symmetrical, moves equally with respiration. Air entry equal on both sides. Normal vesicular breath sounds, no added sounds. Abdomen soft, non-tender. Umbilicus at midline, no organomegaly. Hernial orifices were free. Bowel sounds present. CNS examination, posture, line in warmer with a flexion of both upper and lower limb. Baby was awake with the symmetrical spontaneous movement of all four limbs. Cranial nerve examination, 1, not able to test. 2, pupillary reflex was present. 3, 4, 6, doll's eye movement present. 5, 9, 10, and 12, routine sucking, swallowing present. 7, no facial dysmorphism or deviation of angle of mouth. 8, the baby startles to sound. Neonatal reflexes, sucking and routine reflex present. Palmar and plantar grasp. Morose reflex was symmetrical but incomplete. Step-in and place-in reflex present. ATNR was absent. Motor system, passive tone, posture, universal flux to posture, tone or passive movements appeared to be normal. Active tone, pull to sit, head lag was present. Vertical or axillary suspension, legs extended, neck flexed. Ventral suspension, leg extended.
Now,
Diagnosis,
how is that tone of the baby when compared to the term baby and a preterm baby?
it will be hypotonia will be there compared to preterm. Compared to term. Hypo.
How does the tone evolve during gestation?
Towards term, it will, the tone becomes normal. So that will be.
It will be in universal flexion portion at term, right?
Yes, sir.
Okay, before that it is slightly extended.
Yes, sir.
Okay. So is there anything that you find abnormal in this preterm baby in this examination?
Yes, sir.
Okay. So before you comment on all these things, you are supposed to tell the state to state variation and at what state you are seeing the baby.
Okay.
So this baby, did you observe a feed or KMC session? What do you mean by KMC?
Kangaroo mother care.
What do you mean by that? How do you put it?
Between the two breasts of the mother, the baby's put, the mother should wear a front open clothing and the baby's dress should also be front open. So there is ideal skin to skin contact. The weight of the baby less than 2.5 kg, so gestational age less than 34. Still the child wriggles and crawls around the breast, the KMC can be continued. Normal
In
duration is
what
about
position and posture? That is what the question sir was trying to ask you.
the neck should be extended, facing the face of the mother.
Okay. Frog-leg position is the typical thing that you're trying to explain, okay? What do you mean by a vulnerable
I'm trying
newborn?
to get that word, but she has not come out of that.
Yeah, but she explained everything in that frog-leg posture. Yeah, that's, I think she has put, I'm convinced that you have put at least KMC. Yeah. Okay. So, what do you mean by a vulnerable newborn? I am just concerned about your saying of less than 34 weeks. That was a old recommendation which was revised in 2022 even by WHO. Now they have increased the cutoff from 2 kg to 2.5 kg and from 34 weeks to all preterms. So, what do you mean by a vulnerable newborn in this scenario? Any preterm or low birth weight baby you call as a vulnerable newborn. So KMC can be put for all vulnerable newborns. That is a recent recommendation. And how early you start?
As early as less than 24 hours of birth. If the child is hemodynamically stable, we can start yearly KMC.
Okay. Skin to skin contact at birth?
Yes.
No, can be given for this baby.
No, sir. The
After
baby is-
delivery, you want to take this baby to warmer or you want to put the baby over mother's breast for this baby?
This baby didn't cry at birth, so we want to resuscitate.
Okay.
So
No, if the baby has cried?
we can
No,
put
if the baby has
on the
cried?
mother's abdomen.
No. Less than 33 weeks, you're not supposed to put the baby on that. Less than 33 weeks will need extra interventions to maintain thermal regulation and it needs to be brought to the warmer. Even if the baby has not cried, you will still bring the baby to warmer. That is STSC at birth, skin to skin contact at birth. What is IKMC? Immediate KMC.
Immediate
What do you
KMC.
mean by that?
That is less than 24 hours we start KMC.
We have to target effective KMC. What do you mean by effective KMC?
At least 8 to 24 hours per day.
Exactly. At least 8 hours a day. Very good. Okay, good. Yes, please. So KMC session is always better to identify and you should always comment on how much hours the baby mother is putting KMC per day. What is community KMC?
Anybody in the family can start KMC, sir. Not only the
Post, not necessarily. Even in hospital, anybody can give actually, not necessarily in the community. Community KMC is post-discharge. Even in home, you are supposed to continue your KMC. For up to 28 days, if you put your post-discharge mortality reduces to a greater extent. That is what we target. So KMC we target at 4 levels. Skin to skin contact at birth, IKMC, and your facility KMC, and of course community KMC. Yeah, good.
diagnosis. It is a single male, moderate preterm, 32 weeks. The child was examined at postnatal age of 33 weeks plus 2 days of birth weight of 1.950. Appropriate for gestational age with the risk of sepsis with respiratory distress syndrome treated with surfactant and phototherapy for jaundice, tolerating feeds well with adequate weight gain.
Okay. What do you mean by adequate weight gain at this point of time?
15 to 20 grams per kg per day till 36 weeks of gestation.
Okay. So that is fairly constant at this age and you target at that actually. Okay. So when the baby is not growing well, what are the things that you will consider?
Temperature instability, hypothermia.
Excellent. That is a calmness cause. How will you identify a cold stress?
The mother should the ideal temperature monitoring should be there. The baby.
Okay, axillary temperature measuring is ideally, but how do you suspect a cold stress? What will you do clinically to identify whether it is cold stress or not? What do you mean by cold stress actually? What is the definition of it?
Peripheries will become cold.
Okay, peripheries are chill and the center is warm. That is the indication for cold stress. Okay. So why does cold stress result in poor weight gain?
The body will move to regulate the temperature. The energy expenditure will be spent there, so there will be.
Okay, baby has to spend more energy by
Maintaining the
okay. For utilizing the brown fat, the baby will utilize all the glucose and baby will go in for a GRAS catabolic state actually. Okay. Okay. One thing is cold stress. Any other thing you will consider for poor weight gain? That is one of the commonest cause in this growing preterm.
Sepsis.
Sepsis, occult sepsis is still a possibility. You want to reduce the risk by removing all IV lines and try to practice KMC. Okay. Then
With the feed-in practices, ideal feed is given. Feed
Yes,
in dot.
maybe as far as from your comment, I think feeding adequately, and there is monitoring also, which you have done from your history, that adequacy has been ensured. Yes.
okay. How much volume you target right now? Generally give at this point of time?
We start at 80 ml per kg per day.
Okay. Okay.
Increase by 20 ml per kg each day, sir.
Okay. So currently on day 10 or 11, how much will you, what is the upper ceiling of it?
I will go up to 250. Sir.
Okay. Even 180 to 250 you can give, usually given at around 180 ml per kg, 180 to 200. Okay. So despite giving 180 ml per kg of mother's own milk and ensuring normothermia, this baby is not gaining weight, what do you think of? What are the other common causes?
Ongoing sepsis.
Of course, sepsis can occur at any point of time in a preterm baby, of course, then.
Dyselectrolytemia.
Like,
Hyponatremia.
Hyponatremia.
why should this baby go in for hyponatremia?
Yes.
Oh, those are acute sick conditions. You can't miss actually. Those are
And
not
you are very certain that the baby is on MOM, mother
Yeah.
own milk, not on any formula.
Mhm. So immature renal system loses more salt. So you want to supplement salt. When do you screen for it and how much you can give?
Screen for what, sir?
Hyponatremia. That is one of the commonest causes, as somebody has rightly pointed. The next most common cause, literally, other than these two which we have discussed. And what are the other commonest thing that you will do when there is inadequate weight gain? Do you give any other thing other than mother's own milk?
Fortifies we give, sir. Human milk fortifies.
Okay. What is the role of it? When do you consider?
We start when the baby is on 100 ml per kg. Feed.
Routinely.
Yes. Yes.
Routinely or when the baby is not growing?
So in fact, how long you will wait for the weight gain to occur? Initially, you expect some
1 week
loss
that
as well.
drops. After that, there will be a rise. Term babies will lose a 10% of their weight in the first week, and preterm will lose up to 15% of their weight in the first weeks.
When do they regain?
Subsequently, they'll regain their weight.
When?
Second week.
At what age? At what week? Is that both same for term and preterm?
Okay. Birth weight is reached earlier in a term baby and later in a preterm baby. The more preterm you go, the more later it will take. Even for extreme preterms, if we take, it may take even up to 3 weeks. For these 32-weeker, it may take somewhere around 12 to 14 days. And in a term baby, it will usually take around 7 to 10 days. 7 to 10 days itself, it can regain. And after, of course, as you rightly pointed, after 1 week, there should be some weight gain. The baby should start having some weight gain. Okay. So those are the things which you have to monitor. And what charts you monitor for your postnatal weight loss?
I think we have 5 more minutes, I think.
Yeah. So these are the common problems which you will be dealing with these preterm babies. So one thing is that, have you fed the baby on Pal feeds? Actually, a Pal session, I would recommend all postgraduates to give a Pal to try to find out the nuances of it actually. Then only you can assess a lot of things in the baby. That's always good. And other things, I think she pointed out very nicely. That's overall a very good presentation, and most of the things you have answered correctly. Definitely, I would pass you with distinction if your performance in examination is like this. Yeah. Okay.
What about cup feeding, Manikkumar sir?
Yeah, palliative feeding and cup feeding literally are with the comfort of the mother, whichever she feels comfortable, I think we can give. And there are some specialized cup also for preterm babies, something like the Nifty cup and all. Okay. So those can be tried actually. Yeah, those are good.
Only thing is mother must be trained, or whoever is
Yeah,
the caregiver must be trained enough to feed, like that is
exactly.
important.
Exactly. So having said about palliative feeds, how will you clean a palliative?
In the boiling water for 20 minutes, we'll clean the palate. So
Okay. Okay.
till it was done.
Good. Those are the standard things which we expect to counsel the preterm mother actually. Okay. I think we got all the basics right in preterm care and jaundice. It's perfectly fine. Still, we are not sure why the baby died at around 3 months of age for the previous. We need to explore the details actually.
That is what's
Uh,
still a mystery in my part,
yeah,
which I'm really
worried
very
about,
much
yeah,
eager to
still,
know from the mother.
because unless we
Once
know
I
what it
lost
is,
a
it's very
baby.
difficult to predict whether it will recur in this baby or not. I will not be able to say completely
Till
with
then, I
100%
think the mother
confidence.
won't sleep at all, sir. I'm sure.
Okay. Yeah, maybe. Okay.
Must be able to give a clear, like outlook about how this baby is going to cross
Correct.
that 4 to 6 months. That's more important.
Yes, yes, yes.
Anyhow,
Sure.
thank you
Thank you, sir.
for your excellent presentation, Dr. Priya.
Thank you, sir.
And I feel that attending not a MD postgraduate exam, but I felt like attending a DM neonatology exam.
Okay. Yeah. That was a good presentation. I totally agree with sir. Yeah. Thank you, sir. Yeah, any other doubts from the audience? We'll be glad to clarify.
So thank you very much, Professor Somaseka sir and Manikumar.
Thank you, sir, for the opportunity.
Thank you,
Sir,
sir.
it's a pleasure to have you all. Sir, SPS sir is there? Sir?
Yeah. Fantastic.
Good evening, sir.
Manikumar, fantastic, brilliant. In
Thank you,
fact,
sir.
I enjoyed and I also learned. And the presenter, Priya, fantastic. You are brilliant.
Thank you.
You are brilliant. In fact, I learned from you as much as I learned from Manikumar. Your answers were spontaneous. They came within 30 seconds to 1 minute of Manikumar's bullets and Dr. Somaseka's bullets. A few comments. One is that, the government of India,
Yes.
at least in the northern states, I don't know about Tamil Nadu, has started INIPI. From the exam point of view, Priya, you must know the Intensified National Iron Plus Initiative Program.
Okay, sir.
They have started, where the government of India has made it. I know in Uttar Pradesh they have made it available. 1 ml is 20 milligrams of iron and 100 micrograms of folic acid. The policy is to give it twice a week, 6 months to 5 years in all infants. And only in preterm infants, you start the iron at 2 weeks, and the dose is higher, 4 milligram per kg. Whereas in term infants, you start at 4 months, you give only 1 milligram per kg. That's one. Second is regarding the death of an infant at 3 months. I don't know, a 3-month-old infant doesn't die of jaundice in 3 days. So that history is not plausible. Something was missing. The only way jaundice can be associated in an infant who's 3 or 4 months old, who dies within 2 days, is only extreme hemolysis, where the jaundice could be hemolytic jaundice. The extreme hemolysis occurring at 3 to 4 months,
Extremely
other
rare.
than sepsis or falciparum malaria, which is unheard of in Tamil Nadu, is something very difficult to accept. You could have gone into the history again. Mother would always know. You could have obtained history of abdominal distension, organomegaly, color of the urine, color of the eyes, color of the skin, and gone into details whether the jaundice is really true. Sometimes, in Tamil, they call Vellakama, like severe pallor may be mistaken as jaundice. So that's one thing. So we don't know the cause of the infant. I don't think you can blame any congenital disorder. If the infant had been doing well, must have been some acute illness. We may never come to know. That history would have been helpful. Last is, in the diagnosis, you simply put phototherapy for jaundice, but you have not given the reason for the jaundice in this infant. You must make an intelligent guess. I'm sure you can only, it can even be exaggerated physiological jaundice because of prematurity, right?
Most
Or
likely, sir. Yeah.
maybe there is an underlying blood group incompatibility which we don't know. You have not given details. Blood group incompatibility or other causes of unconjugated hyperbilirubinemia, which includes, hypothyroidism. Hypothyroid. That's one thing you should have definitely mentioned. In this infant, somewhere, I don't know whether you done thyroid screening so far?
Yes, sir.
Yes,
Thyroid was
that's
done.
the only screen done, sir.
And
Only
it's not
screening
enough.
done.
I'm sure Manikumar would agree. In this infant, even a single screening is not enough.
Definitely not.
Yes, sir.
If this is
We need
persisting,
follow-up.
definitely I would go ahead and consider repeating the TSH and monitoring that. Blood group incompatibility and other rare causes of unconjugated hyperbilirubinemia have to be thought of, including, if the infant who died at 4 months had jaundice from birth, something like regular Najar
Regular
or
Najar.
those
Yeah.
possibilities.
Yes,
Regular
that is what
Najar
I
has to
was
be thought
thinking.
of. In fact, in addition to other conditions which can cause jaundice on day one, you have to include regular Najar,
Yes.
which can present with jaundice and intrauterine infection. Severe CMV or even herpes, severe herpes can lead to neonatal jaundice right on day one, however uncommon it is. These are my comments. Excellent presentation, excellent mentoring by Manikumar, and good nutrition points from Somasekhar.
But it is not certainly due to surgical jaundice because that will not kill a child at 4 months. The child will survive for nearly 1 year, till 1 year. Some intervention could have done. So it is not certainly surgical, like biliary atresia. That is very sure for me.
That was brilliant. You would get a DM for your presentation, Priya. All the best. God bless you.
Thank you, sir. Thank you for your wonderful blessings. And
Thank you, sir.
Well done, Dr. Priya. I think the same questions will be repeated in the same order in the exams also. But you had 3 best examiners. So I think you will shine well. Congratulations. Thank you, Dr. Manikumar. Thank you, sir. Somsekhar, sir. And
thank you, sir. Thank you.
Sir.
Thank you, sir, for the opportunity.
for the
Thank you so much.
opportunity, sir. Thank you.
There is one question and one comment in the chat box. The question is IEM screening done before 34 weeks gestation accurate? Question.
Yeah. So basically, it is a screening test, and if it is negative, because most of the catabolic states, whether the baby is stable or not, when the IEM screen is done, most of the time for these preterm babies at 32 weeks, the baby may be acutely sick. But this baby is also on ventilator at that point of time, on antibiotics, which all have the propensity to disturb the reports to some extent. And you have to take it with a pinch of salt. And if at all this baby had a previous documented IEM, then we definitely have to screen. Or else till the time we will wait for stability, and after that we will do. That is the usual time it is being done.
So it's not dependent on the gestational age of the baby.
Yeah, we have to achieve some stability also. Actually, for very preterm and extreme preterm, there is no point in doing an acutely sick baby with some IM screen and trying to find out.
I think it's a comment from Dr. Yamuna. We should conduct a verbal autopsy on the baby's death and antecedent events.
That was discussed. That was discussed.
Yes, sir. Yes, sir. Yeah.
Well discussed, brought out very well.
Thank you. Thank you, sir.
Thank you.
Thank you.
I thank all the participants also. Today there was some problem in the link. So most of the participants joined through the YouTube. Those who can click the link in the PDF can join here. So other people, there was...
Even I too faced the problem initially, Prasanna, because the link comes, like then I went into my Zoom link, then I put my passcode and then only could join. Like
so many people joined in YouTube, sir. We also gave YouTube link.
Oh, yeah.
There were so many people on the YouTube. Next time, I think we'll make sure that the link is perfect.
Sure.
Thank you.
Thank you so much.
Thank you, sir. Thank you, sir. Thank you very much.
Manikumar. Well done, Somasekhar.
Thank you, sir. Thank you very much,
Thank
sir.
you, sir.
Thank you, sir. You are guru for all, sir.
Yes, sir.
Thank you, sir. Thank you.
Thank you, sir.
We'll end the meeting here.
Yeah, thank you. Thank you. Thank you,
Thank you.
Prasanna,
Thank you.
for coordinating well.
Thank you, sir. Thank you so
Thank you
much.
very much. Thank you very much for picking up the right postgraduate and faculties. Thank you very much.
Thank you, sir. Thank you so
Thank
much.
you, sir.
Thank you.
Thank you.
Thank you.